Good morning, everyone. Hopefully you are here for our Saturday symposium on pre-hospital maternity emergencies. My name's Caroline Leach. I'm a consultant in emergency medicine working at University Hospital Coventry, and I also have been working as a pre-hospital doctor for the last 25 years. And working in both of those specialties, we often see patients who have a maternity emergency. And I'll be honest, it's still something that fills me with dread when I'm going to a job and it involves pregnancy or childbirth. Yeah, it's difficult. So that's why we've put this symposium on. We're going to learn the really important facts about each of the topics that we've chosen today. We've got some world-class pre-hospital maternity experts giving these talks, and then you are going to go away feeling a lot more confident. As we're going through each of the talks, I want you to, from a CPD perspective, note what some of your learning points are. And at the end, we're going to run a short quiz so that you can test your learning and see, whether you've got what we want you to get from some of the talks. So I'm just going to go around and introduce some of the other speakers today. And I'm going to start with Steph, please.
Oh, thanks so much, Caroline. Just to check you can all hear me first and foremost. Oh, lovely. So hi, everyone. My name's Stephanie Hayes. I currently work as consultant midwife for the North West Ambulance Service. Just a little bit of background. I started off my career emergency nursing over at East Lancashire Hospital. I've just noticed in the chat, actually, we've got a registrar from Blackburn ED where I work and still do shifts. So hi, Shafi. I worked as a midwife over at East Lancs, so that's in the Burnley area up north, and currently do shifts over at Liverpool Women's Hospital. So really great to be here, and I'm going to cover some of the topics today with Camilla when things go wrong. So thank you so much, and great to be here.
So good timings. Pass over to Camilla, please.
Hi, good morning, everyone. Really great to be here as well. I'm Camilla Main, and I'm so part of the week I'm lead midwife for London Ambulance Service. Part of the week I'm consultant midwife for East Midlands Ambulance Service. And I do clinical shifts at Guy's and St Thomas's, which for those that are not Londoners, that's the hospital that's opposite Big Ben. Have mainly worked in the UK, but have also worked in Haiti and New Zealand and Tanzania and the Netherlands. So yeah, I'd like to leave the UK regularly to go and have fun elsewhere. But yeah, really excited to be here.
Thank you. And Dawn.
Good morning, everybody. My name's Dawn Kersnake, and I am the consultant midwife at South East Coast Ambulance Service, which sits just under London. It's Surrey, Sussex and Kent, for those of you that are rubbish at geography like me. And today's a really special day for me because it's exactly 33 years ago that I joined the NHS today. So that's exciting. I only just realised it 2 seconds ago. So like Steph, I started my career as an A&E nurse and then progressed into midwifery. And I still do my clinical shifts in a hospital in Greater London, Kingston, in Surrey, and but I'm full-time at South East Coast Ambulance. So I manage a couple of shifts a month over there. Thank you very much. Lovely to be here.
Apparently you've got a big cake fine for the anniversary. So.
Oh God, okay.
And last but not least, Aimee, please.
Hi, good morning, everyone. It's so lovely to be here. I'm Aimee Yarrington, and I started my career in the NHS 25 years ago as a nursing cadet. And I've been a midwife for just about 20 years now. And then I joined the ambulance service 13 years ago, and I've been a qualified paramedic for 12 years. So I practice both as a midwife and a paramedic. We started pre-hospital maternity care when there was pretty much just me and Amanda Mansfield battling it out, just the two of us. And then I am so happy to see that there are so many midwives now working in pre-hospital maternity care, bringing forth this hugely important topic, which we have been shouting about for so many years. And now I've got these wonderful colleagues here that support us in this cause, and it's so wonderful. And it's thanks to people like you, Caroline, that keep shouting about how important this is and how we need more education for clinicians facing this such a scary topic for a lot of people, where training is very often minimal, but the stakes are the highest. So yeah, it's wonderful to see so many of you here, and thank you again for inviting me.
Great. So it won't be scary after they've done all of this online
Yep.
teaching. They'll be sorted. Aimee, if you want to start sharing your screen, and we'll get ready for the first talk. So we're going to start talking about normal childbirth, and then following that, we'll talk about when things go wrong. So I'm going to hand over to you, Aimee, to start presenting.
Okay, so can everyone see my full screen?
Yeah.
Yeah, wonderful. Okay, so I've got the very easy part of this topic, in my opinion, because I'm going to talk about the normal part of birthing. Apologies if I look a bit pink. It's because my big screen is making me very pink. I'm not like highly embarrassed, but it's just the corner of my office. So we're going to take a little bit of a look at, if my screen would move on, about some of the key important points around the normal birth. I'm not going to go through the whole how to catch a baby thing. We're going to look at some of the really, really important points and topics that sort of pick us out. The whole, do we stay, do we go, a bit about cord management, and then the most important thing is about this post-birth issues. We've already covered who I am. As I say, I'm still currently registered, still currently practicing as both a paramedic and a midwife with West Midlands Ambulance Service, and I've got a midwifery contract at the Royal Worcester Hospital, where I do my midwifery practice. So when we talk about normal birth, then a lot of the births that we go to as pre-hospital clinicians, they're very often either the baby is out, which is brilliant. We can take a big deep breath and we can just manage the rest of the session. But the really, really difficult part isn't it, is when we get to that labouring woman or birthing person, and we're in this dilemma, aren't we? This quandary. Have I got time to get to hospital? Do I leave now? Or am I staying and catching this baby? And it's a real difficult decision. And it's one that, you know, as midwives, we don't always know the answer to, because let's face it, we don't know when this birth is actually going to occur. You know, we don't know at what point this baby's actually going to be born, because all births are unique. All births are completely individual. We don't have this sort of, you know, crystal ball as to when this baby's going to come out. And I get lots of clinicians saying to me, you know, well, you know, if we could just, you know, do this, or if we could just do that, then, you know, we would be able to know. But the truth is we don't. We have to make this dynamic assessment about what's going on to make the safest possible decision, don't we? So ultimately, we're looking at, you know, and I'm not going to sing it, don't worry, I'm not going to start breaking out into the song. It's the whole, do I stay or do I go scenario? So the key things that we're looking at here in order to stop on scene with this woman is, the first thing first, have you got any signs of imminent birth? And we're going to go over those signs of imminent birth to recap and refresh your memory on that. If you've not made a full assessment of this woman in labour, you must not move anywhere. You must make that full assessment, because without that assessment, you can't make that decision. Obviously, if you can see the baby, okay, the caveat to that, though, is at the bottom point, which is if you've got any part of this baby presenting other than a head or a bottom, then you must go, okay? When we talk about presenting part, what we're looking to see is either you've got the back of the baby's head, you've got the occiput, or you've got the buttocks, okay? If you've got a hand or a foot, you must get on and go straight to hospital. Those babies are not going to be born pre-hospital. We must get those on and get them gone. But then you're in that grey area then, aren't you? If you've got no signs of birth imminent, you know, if you're confident that you can make it to definitive care, then we're going to be going. We should get on and go to hospital, because ideally the safest place for this baby to be born is obviously in a hospital with maternity and obstetric clinicians, where this, you know, woman is safe to give birth. But when we're talking about this whole assessment and looking at, you know, what actually what we're looking for when we're talking about whether birth is imminent or not, we've got to remember that this whole birthing process is a complete balancing act of hormones. So the main hormone, obviously, that makes the uterus contract and ultimately dilates the cervix and pushes the baby out is oxytocin. Okay, so oxytocin is the hormone that makes the uterus contract, drawing that cervix upwards and ultimately pushing that baby down in order for it to be born. So we've got oxytocin and we've got this lovely hormone melatonin, which acts with the oxytocin to make it extra strong to help push those hormones down and create those lovely strong contractions. But on the counterbalance to that, we've got the hormone adrenaline. Now, obviously, adrenaline is generally released in our fight or flight instinct. And when you get a release reaction of adrenaline, this causes the oxytocin levels to fall. So as we get a rise in that adrenaline, we get a reduction in that oxytocin level. So if we get that reflex release of adrenaline, for instance, say an ambulance crew arrives and you're in the middle of labour, even if you're expecting that ambulance crew or those pre-hospital clinicians to arrive, you're still going to have that sort of instant rush of adrenaline, which obviously in turn is going to reduce the amount of oxytocin. And if that happens, that will have this effect on the contractions, reducing. And I often hear this story of clinicians that will say, well, we got there and she wasn't really having any contractions, so we made the decision to move, and they just ran out of the house. They got her on the vehicle, which, is what we're taught to do. We're told to go and all the rest of it. But they hadn't given that chance for those hormones to sort of rebalance and resettle. And then, of course, she gets on the back of the ambulance. Obviously, the adrenaline levels fall, her oxytocin surges, and more contractions come, and there's a baby being born. So it's this massive balancing act and this massive decision. And it's a really difficult clinical decision to make, because none of us midwives on the call will be able to give you the definitive answer, because every single labour is different. And that's why you have to make that decision individually for each clinical situation you are in. So when you're faced with this really, really difficult decision, one of the key things that you need to look for is, have you got any signs that your birth is imminent? Okay, so when we talk about imminent birth, these are the sort of things that we're looking for. Now, you don't have to have every single one, but you need to have, these are the signs that are going to tell you that your baby is about to be born and that we must be preparing at this point for this baby to be born. So what we're looking for in the woman in particular is a type of contraction called an expulsive contraction. Now, notice I haven't said anything about they will be coming every so many minutes, because contractions do not come in a regular routine pattern for every single woman. And you must not be taken into this trap that if a contraction is not coming every 1 to 2 minutes, she's not ready to have a baby, because that is just not true. The contractions that come when the baby is imminently about to be born are expulsive contractions, and those are caused when the baby's head is dropped far enough down into the pelvis that it pushes on those muscles of the pelvic floor, and this causes a reflex massive release of oxytocin, and the oxytocin causes what's known as the fetal ejection reflex, or the FER, and that fetal ejection reflex causes these expulsive contractions to physically push the baby outwards. Okay, and you'll notice when you look at these contractions, they will be different to the contractions she's been having during the rest of her labour. So you'll physically see that fetus being expelled, and with that you'll get the woman instinctively pushing, and she will instinctively start to bear down. It's something that you can't stop. It's something that no amount of telling her to breathe on the gas and air or don't push, it will happen. It's a reflex. It automatically will start to happen and will start to expel that baby. Okay, so you get that instinctive bearing down. And we're not telling a woman, we're not coaching this woman at this point. We do not tell her to hold her breath. That's really important, that we don't tell her to hold her breath and push down, because we don't want to do this closed glottis, because by doing that, by telling her to hold her breath and push downwards, what we're effectively doing is causing her to become that bit hypoxic. She can also then as well become sort of hyperventilating if she starts to breathe too quickly. So we just tell her to go with whatever her body is telling her to do at that point. We just go with the physiology. If her body's telling her to do it, it's doing it, it's coming. So sometimes you get this change in behaviour. Some women, when they hit this point of what's known as transition, they sometimes become a little bit, uncooperative. The protective mechanism starts to kick in because they know that their baby is about to be born and they have to go into protection mode for their baby because it's all physiological. It's a completely physiological process at this point. So that's what you would see with the woman and her behavioural signs. But externally, if you were to gain consent and ask to visualise the vulva, what you would see externally is the perineum area, so the area of skin between the vaginal opening, or what we call the introitus, and the anus. That will start to bulge outwards as you get the pressure of that baby's head pushing behind it. Another key sign, anal dilatation, or that feeling that they need to have a bowel movement, that they need to have their bowels open. Again, another key sign that that baby is very much on its way. This is why when we have a lot of preterm babies, one of the things that happens with a preterm birth is they very often don't get the same pattern of labour. They don't get a lot of contractions. They just sort of get some abdominal pain, and then they have this overwhelming urge to have their bowels open. So they will sit on the toilet, and that's why, unfortunately, a lot of babies are born down the toilet because the signals are the same. You have that same urge and that same sensation that you need to have your bowels open. So lots of babies are born down the toilet because of that physiological process and that physiological signal that says you need the toilet, so you go to the toilet. The other thing about bathrooms as well, and I find this a lot when I'm practicing, is that women feel safe in a bathroom. So when you've got somewhere that's a small area where you can see everything and you can close and lock the door, that's an area where a woman feels safe and secure because she's in a in a cocooned environment. Very often bathrooms, it can be made a bit darker, and women like the darkness. We'll come on to light in a second because that's a really important point, and we'll talk about safety and darkness in a moment. But the bathroom itself can feel that cozy and comfortable environment, and very often women are in the bath as well. As we know, very often women want to have water, etc. So the bathroom is very often a common place that we find women. Things that you'll see externally as well. So you might obviously start to see the vaginal opening start to gape. You might see the presenting part. So it's really important that we distinguish between presenting part and crowning, okay? So the presenting part is just when you see the initial part of the baby that starts to appear. The crowning is much, much later on, as if the baby was wearing a crown. So when the widest part of the fetal head is born, that is the crowning point, not before then, okay? You might also at this point see something known as the purple line. This is not a particularly evidence-based piece of evidence, if that makes sense. But the purple line is something that I've used a few times in my midwifery practice, and I often talk to it about with pre-hospital clinicians because there is like a pressure marking that appears on some women from the anal margins up to the natal cleft, and when that line is said to reach the natal cleft, the woman is said to be birth imminent, so fully dilated. Not that we would know about things about that as paramedics, pre-hospital clinicians, but the purple line being visible is often an indicator that birth is imminent. That, along with a rhomboid shape that appears at the lower half of the sacrum, known as the rhombus of 𝐦𝐨𝐬𝐬 or 𝐦𝐨𝐬𝐬𝐬, when those are visible as well, again, that's a sign that that baby is really low down and putting pressure, and again, birth imminent. And this is also the physiological point at which the waters should break as well. They don't always break at this point, but physiologically, this is where the baby, the waters should break just as the baby's about to be born, so that everything is given a clean down and come through. But as we know, as pre-hospital clinicians, sometimes that doesn't happen. And sometimes these babies are often born within the sac and within the membrane. I know of more pre-hospital clinicians that have caught babies in the core than midwives, because often one of the first interventions, unfortunately, that happens when you're in a hospital situation is waters are very often broken. As a theory that it speeds up labour. There's not a lot of evidence that it does, but it often happens. And I say, because we don't do that pre-hospitally, very often we get these babies that are actually born in the cord as well. If that happens, we don't interfere with the membranes as they're on their way out. So we don't pierce them or cut them when the baby's actually being born. And then once the baby is born and the baby has emerged, that's when you can peel the membranes back over the face, etc., and get the baby out of them as quickly as possible to obviously get the baby breathing, etc. So once the baby's been born, then, so once the baby's been caught and come out, the next thing that I want to go talk a little bit about is a bit about the cord management. So the umbilical cord doesn't technically need to be cut if the baby is happy, if the baby is healthy, if the baby is crying, until it's gone flat, white and opaque. So until it looks something like this picture right at the bottom right-hand side. So generally it takes somewhere between 10 and 15 minutes in order for the cord blood to be taken back into the baby. It can take a little bit longer. And if you were to touch the cord at the top left-hand screen, you would feel a small pulse going through that cord as the baby is drawing its blood volume back into its body. Because don't forget, the blood which is in that cord is actually the baby's circulating blood volume, okay? So it's really quite important that that baby gets that volume back. After about 60 seconds, we know the baby's had around about 80% of that cord blood. So it is accepted within the NICE guidelines that following 60 seconds, you can clamp and cut the cord. But obviously, 𝐥𝐢𝐤𝐞 guidelines state that if it's needed to, it mustn't be done before 60 seconds. It can be done after 60 seconds, but ideally you want to wait until it goes flat, white and opaque. And we know at that point, then the baby's had all of its blood back into its circulating blood volume. And once it's gone flat and white, it's absolutely quite safe to clamp and cut. So why is it important then that that baby has all of that blood volume? So we know that within that blood volume, we know that obviously their baby's getting an oxygenated blood supply. So it's getting that oxygenated blood back from the placenta. We know that it's obviously getting that blood volume, so it's increasing the baby's iron stores, so increases their red blood volume supply and also the white blood volume supply. And there's lots and lots of evidence ongoing around the really important stem cells that are contained within that baby's umbilical cord. This is not just for term babies, this is for preterm babies as well. And waiting that 60 seconds with a preterm baby can be absolutely vital, because we know that with a preterm baby that it decreases the risk of intraventricular brain hemorrhaging, of enterocolitis, of late onset neonatal sepsis, obviously through things like need for blood transfusions, and all these massive, really important aspects, simply by not clamping and cutting that cord for a minimum of 60 seconds post-birth. Dawn's going to talk to you a little bit later on about newborn life support. So I'm not going to go into the newborn life support side of things, but ideally, we don't want to be clamping that cord for 60 seconds until you've made that full assessment of that baby, because that's really, really important. Obviously, once it's gone flat, white and opaque, it is absolutely safe to clamp and cut. And if you'll notice, the new 𝐥𝐤𝐞 guidelines have changed. It used to say you've got to go at least 15 to 20 centimetres from the baby. They now state up to 5 centimetres away. realistically, there's no hard and fast law about how far away that you clamp and cut the cord. You've got to feel safe, you've got to feel comfortable, and we don't want to go chopping off any fingers, toes, or genitals. That's the most important. But the other really important factor is that we don't want the baby getting cold while you're doing this, because obviously as soon as the baby is born, we need to ensure that the baby is dried and that the baby is wrapped up, ideally placed skin to skin. But while all of this is going on, you've got a cold, wet baby. So that baby is vital that it is kept warm. Okay, so you must ensure that you dry the baby off thoroughly, placing the baby skin to skin with a minimum of 2 towels over the top of that baby while all of this management of the cord is going on. Okay, because we do not want this baby getting cold at this point. Systematically, we'll go through that one, we've talked through that one. Move on to that one. So post-birth then. So now we've got this issue, haven't we, where we've got 2 patients that we are now responsible for, okay? So I'm going to talk a little bit about our management of our woman, and then we're going to talk a little bit about the management of the baby, okay? So with our woman now, immediately after this birth has occurred, this is probably one of the most critical times that you really need to be on your guard, because it's at this point where things can start to go a little bit awry. Your bandwidth kind of goes off schedule a little bit and time just flitters away. And it's really important at this point that you keep an eye on your time frames, because this is where, if things are going to potentially go a little bit wrong, they can do, and it can have sort of catastrophic outcomes. So we really need to keep on track at this point. So once the baby is born, ideally you want one clinician focused on the woman and one clinician focused on the baby, so that both get the right amount of care. Obviously, this is probably going to be the first time that you're going to perform a set of observations on your woman. If you've walked in and your lady has been in the throes of birth imminent, you potentially will not have had any chance to do any observations on your woman. But right now, it's really important that you get a set of observations. So you've got a baseline set of observations at this point. You'll need to palpate your uterus, okay? So you need to find that fundus of the uterus and palpate it, because you want to know its consistency. You want to know whereabouts it is on that woman's abdomen. So in order to palpate that woman's abdomen, so you take the side of your hand, you place it on her abdomen and start just above the umbilicus and start working your way down the umbilicus. And what you want to feel is the fundus of that uterus. So you want to feel that nice dome top of the fundus, and it should feel hard and solid like a cricket ball. And it should just sit just below the umbilicus. And you want to feel it nice and hard. That's what we want to be feeling. And we want to observe for any signs of bleeding. Immediately after the birth, there shouldn't be any major signs of bleeding until the placenta starts to separate, okay? So you can see here in this picture, on the right-hand side, we've got the placenta that's still situated onto the uterine wall. And as that uterus contracts, you can see that lovely contracting of the uterus as that bulky muscle thickens up. We get a clot that forms behind the placenta, and that helps to push the uterus down. As that placenta falls into that lower segment of the uterus, the woman again will get that urge to push, and she will expel her placenta, okay? Now, as pre-hospital clinicians, we don't manage the 3rd stage of labour. That is something that happens in hospital. So we do not have a way of managing, in effect, the 3rd stage. But you may potentially see a placenta be expelled at this point, okay? So what we would do at this point is observe, making sure that we're observing for signs of bleeding. And as that placenta separates, okay, you should get a gush of bleeding, okay? So there will be a gush as that placenta separates off, and that's generally around 200 to 300 mils of blood, okay? And this is the point that a lot of clinicians will get a little bit twitchy and a bit worried, because they're like, oh my gosh, there's been this big gush, what am I going to do? This is completely normal, okay? Completely normal. As that placenta separates, okay? So don't panic at this point. You'll see the cord start to lengthen, and the cord will have stopped pulsating because you'll know it's separated off the side of the uterus. The cord will stop pulsating and you'll see that cord start to lengthen. So ways that we can assist this happening, if you're, still on scene at this point and we're within our time frame of 20 minutes, so we give this 20 minutes and at that point we're going, okay? So this is why I say we've got to keep our eye on the time frame here. We must absolutely make sure that everybody is calm, everyone's collected, that we're maximising our natural oxytocin that we've got flowing, okay? We must not, absolutely categorically must not pull on this cord, okay? We really, really must not pull on this cord. Cannot emphasise enough how important it is that we don't pull on the cord. I've also put something there about emptying the bladder, okay? If it is feasible, if you have a method of doing so, and I don't recommend walking women to the toilet at this point, but if you have a urine cup or something like that where the woman can empty her bladder, if she is uncomfortable and she says that she needs to have to pass urine, it's advisable that she does pass urine because a full bladder will prevent that uterus from contracting down effectively, okay? But it's not something that is an absolute imperative. You must do this, you must do that, but it's a consideration. If you can think about it, if she wants to empty her bladder, absolutely, but always being cautious of the fact that there is not excessive bleeding, etc. on scene. If there is no sign that your placenta has been expelled within 20 minutes, okay, you must get on and transfer, okay? This is where, as I say, time tends to slip out of the window, and it's really, really important before you realise you've been on scene an hour and all of these things have happened. So it's really, really important that you keep that overview of your time frame at this point so that we're not having excessively long time on scene, okay? It's really, really important. So the other point then about baby, okay, it's really important that we keep the baby warm while all this is happening, while, the mum is sort of coming down after this massive event that has just happened, that we keep this baby, first and foremost, that this baby is kept warm. Now, obviously, skin to skin is the best way to do that, and it doesn't necessarily have to be skin to skin with the mother. It might be with a partner or somebody else who's on scene, okay? But it's really important that it is not like these pictures here, that the baby is covered, okay? That we have at least 2 layers of towel on top of this baby to keep this baby warm. And also, what's the key thing that's missing from all of these babies? A hat. None of these babies have got a hat on, okay? So obviously in all of the maternity packs, it's really important that this baby has a hat on because they need to be kept warm. We cannot emphasize enough how important it is to keep these babies warm. Obviously, another way that we can do things, if the mother wishes, is she can breastfeed. Breastfeeding, again, is a really great way to increase that natural oxytocin. Also helps with maternal bonding, etc., to keep the baby warm. To initiate feeding and to help with that natural oxytocin. Keeping them warm, as we've said, and I'm very aware I'm rapidly running out of time. If we can keep talk and chatter to a minimum, that always helps, obviously, to keep things calm and keep things to that sort of low level. Lighting, as I said we'd come back to lighting. Lighting is important. Lighting is important that it's kept safe, okay? If you are called to a situation where there is a home birth and we've been asked to do a transfer, you'll walk in and very often you'll find there's just one tea light in the corner because everything else is in darkness. That's not appropriate for us, okay? As much as low lighting is nice and it's good for oxytocin, we need things to be safe and we have to have safe lighting, okay? So it's important that you can see exactly what is going on, okay? It doesn't have to be every single light blazing, but you need to be able to see where you're putting your feet and you need to be able to see the colour of your mother and you need to be able to see the colour of your baby to ensure that there's no signs of deterioration. And I know it's very easy for all of us to say, but keeping calm again is really, really important. It's really important that you keep yourself calm, because the minute that you start to panic and lose your train of thought, that again is where everything else starts to, lose track. And yeah, it kind of all goes to a little bit of a pop, doesn't it, when you lose your train of thought and your bandwidth goes. So it's really, really important. Just a note to finish off, because one of my key things is about placentas. The reason that we don't pull on placentas is because not all placentas are the same. There's some very different variations of placentas. And one of the things is, if you pull on a placenta that hasn't separated off the wall of the uterus, you can technically pull her uterus inside out, which is, again, is not good. But there are lots of placentas that are built very differently, as you can see, with lobes that separate off, etc. So by pulling on those, you can leave parts of placentas behind, which can lead into all sorts of problems a lot later on. Sorry, I could talk about placentas all day. I could do a whole session on placentas. But that's, oh my gosh, look at that, spot on time. That's got to be the first time for everything, hasn't it, Caroline? Definitely. But thank you very much.